Treatment for gastrointestinal stromal tumors is a well thought out field involving multidisciplinary treatment. You go through multiple lines of oral therapy with imatinib, sunitinib, and regorafenib, with multidisciplinary management along the way, watching for the occasional patient that would also benefit from surgery. Originally, the treatment for GIST came out of the mutations found in KIT and PDGFRA with imatinib. And so we found this wonderful inhibitor of KIT really transformed an untreatable disease to something that in the advanced setting became palliatable. And then the next step we found is that in patients that originally failed a low dose of imatinib would respond to a higher dose of imatinib. From there, we found the next study that was to come out that really changed the landscape is we actually have a second-line therapy in sunitinib. And then there was, a few years ago, a randomized trial looking at regorafenib. And in regorafenib, we then established a third line of therapy. The problem is that molecularly, putting pressure on its oncogenic driver allows for new mutations that evolve and cause tyrosine kinase inhibition resistance. And so we've been looking now for new drugs to these new resistance mutations that arise in the hopes that we can actually inhibit those and then develop the fourth and fifth and sixth lines of therapy so that we can keep pushing overall survival in patients with gastrointestinal stromal tumors. In terms of toxicity, imatinib for most patients is well tolerated. It does have some problems with fluid retention and some periorbital edema, but in general, we can make imatinib well tolerated. I think the problem goes that if you've been on a well tolerated medication for a very long time and then go from that to say something like sunitinib, which to a gastrointestinal stromal tumor patient is actually a step up in toxicity. In fact, many of them don't tolerate it well, and because of that we end up either playing around with it, which would lead to earlier point mutation appearance, or they just don't want to take it. And then they go from that to regorafenib, which has all its problems with hand-foot syndrome, and then it's not well tolerated either. So we're still looking for ways to make these tyrosine kinase inhibitors better tolerated by patients, or just to find better tyrosine kinase inhibitors that are just more tolerable.
The mutation of PDGF receptor and KIT were identified 20 years ago in gastrointestinal stromal tumors. They are actually the active drivers of these tumors. These mutations are mutually exclusive. Actually, the majority of GISTs are equipped with activating mutation of KIT, and about 10 to 15% are equipped with another mutation of PDGF receptor alpha. So there are about 15% of the GISTs which are associated with different mutations on other genes, but the majority of GISTs have these mutations on these kinases. This is very important because these mutations are actionable, which means that they can be treated by tyrosine kinase inhibitors, and this actually was the driving force for the development of imatinib, sunitinib, and regorafenib for the treatment of GIST in first, second, and third line, because these kinase inhibitors block these activated kinase on the tumor. Now, the problem, of course, is also that resistance may emerge, and what we know from a large number of publications now is that the resistance observed in GIST comes from the selection, the clonal selection, the Darwinian selection of resistant clones equipped with the same KIT and PDGF receptor alpha mutated proteins, but with additional mutation encoding for resistance to these tyrosine kinase inhibitors. So KIT, PDGF receptor alpha are mutated, they are the drivers of GIST, and on top of that, if exposed to a targeted tyrosine kinase inhibitor, they may be further mutated and develop secondary resistance.